Good afternoon and welcome to our COVID series, Matters of the Heart. I'm very pleased to introduce Dr. Daniel Sado, who is a consultant cardiologist at King's College Healthcare and an expert in cardiomyopathy and cardiac MRI. We are also expecting Professor Susanna Price, who is a consultant intensivist and cardiologist working at the Royal Brompton. She is at the front line at the present time, managing a patient, and will join us partway through our webinar. Today's subject is COVID and matters of the heart, and we'll be exploring both the acute effects of COVID and also some of the long-term effects that COVID has brought to us. If you'd like to ask questions for the Q&A function, we will endeavour to answer those today. For those that we don't answer, we shall reply after the webinar. So without much further ado, I'd like to kick off with Dan, who kindly is going to share some slides with us. Dan, thank you very much for joining us.
Thank you so much, Nick. It's very kind. So I thought I'd perhaps just open up, and I know that generally we haven't done this through the COVID-19 sessions, but I just wanted to show some slides to show some imaging of the heart, just because it's so relevant to what with some of the stuff we're going to talk about later on through this. And it just gives you an idea. It's much easier to give a feel for this if you can actually sort of see, in effect, some of the stuff that we do in cardiac imaging. And this is really pushed towards the issues that we have in trying to image patients with myocarditis with MRI. So part of the reason I have two interests in the COVID-19 field. One is myocarditis, which lends itself in a fairly big way clinically to cardiologists who do cardiac MRI, because it's one of the better non-invasive ways to make the diagnosis. I'm also Southeast London lead for post-COVID syndrome, along with Hannah Sinclair, who's at GSTT. So I have two sort of interests in this. So let me just screen share with you. Show you this. So this is just some images to just give you an idea of what MRI does with the heart. I'm not going to show it on a bigger view, just because the movie I'm going to show you in a second doesn't run so well when I use the larger screen view of this. So when you image the heart, there's various things you may want to know, but if you're debating a diagnosis of myocarditis, which is one of the main interests in terms of what COVID-19 might do to the heart, cardiac MRI is a good way to do it. Along with echo, you can do cine imaging, which I'm going to show you an example of in a second, which shows you the movement of the heart, and that allows you to work out things like ejection fraction. So you get beautiful images of that on MRI. But in most patients, that doesn't add a huge amount to what you get from echocardiography. Where you get the extra bit is imaging inflammation and imaging scarring. This is where echo finds it much more difficult. Echo is less good at tissue characterization. So for inflammation, we do T1 and T2 weighted imaging, which I'm going to talk a little bit in more detail about, and what's called late enhancement imaging, and scarring is also based around late enhancement imaging. So in terms of cine imaging, you get a nice picture like this of the heart. So for the non-cardiologist in the audience, this is taking you back to preclinical to try and think about the anatomy that you studied. So here we have the aorta. This is a three-chamber view, so we take lots of different views of the heart. Three-chamber view, this is the aortic valve, flicking open and closed in here. This is the left ventricle. This is the anteroseptum, so the dark bit is the muscle contracting in and out. Around here is the posterior wall of the heart, so septum, posterior wall. That bit in there is the right ventricle that we're not cutting very well in this view. This view is designed to look more at the left ventricle. This is the mitral valve here, and this is the left atrium. And you can draw, in effect, to work out ejection fraction, you can draw, in effect, circles around this that allows you to measure the size of the heart in systole, the size in diastole, and the computer will do a calculation and say the ejection fraction is whatever. In this case, it's normal. So this is a patient who'd actually had myocarditis from COVID. This is a 6-month follow-up scan where his left ventricular function is normal. The late enhancement imaging we do is a lot of, sort of, if you like, the big plus, if you like, that we have in cardiac MRI. So what we do is we give people an injection of gadolinium, very commonly used contrast agent in MRI scans for all different bits of the body. It will get outside, it's small enough to get outside of capillaries. but it's too big to get into cells, so it won't pass through cell membrane. So it will collect in the extracellular space. So where you have more extracellular space, you get more gadolinium, and you can use that. It creates an MRI signal. You can use that to image things. So this is a patient who's had a heart attack, left anterior descending artery STEMI. What you should see is the myocardium here should look black. Where it's all bright white, this area is taken up, shed loads of contrast, and that is because there's a load of scar in there. So lots of collagen in the extracellular space as if in effect sucked in more contrast. So that's what you might see in a heart attack, where the subendocardium, the bit on the inside, will be involved. In myocarditis, the bit on the inside, the subendocardium, will be spared. And this is the same patient I just showed you before with the cine movie. He's got little patches of white stuff through his myocardium. And in fact, it's not affected his heart function at all, but he's been left these are little small areas of scarring. Next thing with this, let me just go back onto the bigger view here because it's a bit better for this bit. That last bit is the inflammatory stuff. So we can look at T1 and T2 mapping, and these are new techniques that have really been piloted over the last 10 to 15 years. So my MD research was using this, particularly T1 mapping. And what you're seeing here, all tissues in the body have T1 and T2, if you like, natural to them. So these are magnetic signal constants that are different in different tissues and allow you to see the different tissues for what they are. But if you put sort of abnormality, if you put, for example, too much water, too much collagen, things like amyloid into the myocardial tissue, you'll get different T1 and sometimes different T2 signal. T2 is very, very specific for water. It's very good at looking at inflammation. T1 is very sensitive, but actually fairly poorly specific. Lots of things can make your T1 go up. What you're seeing on the picture here is each little pixel is given a color based upon this color lookup table based on its underlying T1 here or T2 here. And you can draw a region of interest around it so that you work out the average T1 signal in that region of interest, which in this case is 1050. And if you're with your academic hat on like me, you can put 100 people, 100 healthy volunteers through a scanner and work out what the normal should be, which this is normal. But you know that if it goes above 10,080 in our scanner, that's a high T1 signal. Something's in the myocardium that shouldn't be there. Same concept for T2. Normal for us is up to 50. This patient's 44, completely normal. So this was the post-COVID patient, 6 months down the line, no inflammatory signal whatsoever, but has been left with a little bit of scar. Just to give you an example of florid abnormality, this is a patient who had, this was pre-COVID, so he had quite nasty acute viral myocarditis. If you look what you get here in your region of interest, you can already see this looks much brighter. It's 1214, normal's up to about 1100 with this. So there's a lot of high signal coming from something. And when you look at the T2 signal being high, that's telling you there's a load of water in here, 61. And in fact, you can see by eye, the normal myocardium will be much darker purple than this. So this, for this gentleman, the viral myocarditis has affected quite a lot of his myocardium. Typically in viral myocarditis, we see the posterior wall affected. Sometimes you can see lateral, sometimes inferior, sometimes anterior. The septum is the least most likely bit of the heart to be affected. So it tends to be a fairly focal process. And one of the key things to remember when we start talking about myocarditis down the line is that the sequences I've just shown you with T1 and T2 mapping are really good, but they are less good in patients with thinner myocardium. That will often be the case in people who are younger, and particularly females. Females will have thinner myocardium than males. It is less good when patients have got fast heart rates, which is an issue, of course, for many in post-COVID syndrome. And it is less good when you look at areas away from the septum. And if you want an example of what I'm getting at with this, you can see how thick things are here. You draw a region of interest in here. There's lots of purple to get in here. As you come towards the apex, the heart will normally thin down, and this looks very bright. You might think this is abnormal. Actually, it's just the fact that the myocardium here is very thin and it's right up against blood, which is very bright. So inside the pixels here, you've got blood and myocardium. So you can't do anything with this. And again, here it's quite thin. So you can't do anything with that. And that's part of the problem that I think we've had in the literature using this sequence, particularly in the more fitter population. This sequence is good for the sicker population like this, but for the sort of younger, particularly females with fast heart rates, the sequence is less good. So I hope that will be helpful just to give you some idea of some of where the conversation is about to go. Let me come off the share. Share, there we go. Right, cool. Thanks for letting me do that bit.
Thank you very much, Daniel. Sort of demystifying that art, which is MRI. So it's really helpful to see that. I mean, there have been studies that we discussed previously around 50% of patients having. I think Imperial had a series of patients who after COVID had abnormality in MRI scan. How do you interpret that, and is that the level we're looking at?
So broadly speaking, I think if you purely look at myocarditis, you've got three potential groups of patients that you need to consider here. You've got the patients who get unfortunately really sick, who Susanna will talk about, who actually often will not meet me. They're going to end up often coming into hospital very sick and end up on intensive care. And sometimes if they're really, really very sick, end up actually needing tertiary or quaternary referral on from there. You've got the group of patients who might meet me, who come in with chest pain, unwell, not bad enough for ITU, but end up on a cardiology ward. And then you've got the patients who some have studied, who actually just out in the community, who are actually really quite well with this. I think the first thing to say is if you look at post-mortems, so the best way to diagnose myocarditis is with post-mortem. You know, at the end of the day, histology is the gold standard for this. The post-mortem studies don't show a lot of myocarditis. You generally see, give or take, about 1 or 2% of patients at post-mortem. Now, bear in mind, post-mortems are being done on people who may well have died predominantly of a lung problem. So, you know, you are looking at a particular group in doing that, but it is also all comers with the worst COVID as bad as it's going to be. So that's the first thing to say. If you look at the data from the Imperial group for myocarditis, they looked at a group of patients who were troponin positive in hospital. So they were reasonably sick. They weren't super sick, so they weren't sort of ITU intubated generally type sick. It was more the sort of middle of the road sort of hospital admissions, I think, the majority of the patients. But they're all troponin positive. Around about 25% had myocarditis. But you find a mixture of other things. So you find some who've had heart attacks, and I think some of the questions we're going to look at are around myocardial infarction. And you see, in terms of the last bit, where you look at patients outside of hospital, there's a lot of debate around this. This is the most difficult group to study, in my view. One paper has suggested an awful lot of people have got changes on MRI. The significance of this is unclear. Is it just a problem with the technique, which it may well be? And I don't think we're assuming that seeing something that's subtle on MRI equals something problematic. It may not do. And I think there's an awful lot more work to be done in that group, particularly, as I say, when you look at the really sick end of the spectrum and see that actually the majority of them, I mean, the last thing to say with the middle of the road group for the Imperial, 89% of them had normal heart function. So although a lot of them have got heart involvement, they've had high troponin, only about 1 in 10 has actually got left ventricular systolic impairment on the back of that, fortunately. So
that's really interesting. And just to remind people, troponin is a cardiac enzyme that's released when the heart muscle is damaged. And we do know that the higher troponin, the worse the heart failure, and probably the worse the outcome on the stay in the ITU. So it does bear some relevance, and perhaps Susanna will talk about that if you manage to join us. You talk about normal heart function, but do you think these scars are going to store up the problem for the future? So are we going to look at something in 3 to 5 years' time or longer?
So the answer with this, of course, is always hard to know. If you look at, so my clinical hat is in heart failure. The majority of patients I see in heart failure clinic have not had myocarditis. The vast majority, I mean, the majority are ischemic heart disease. So the majority of patients in heart failure clinics are ischemic cardiomyopathy. So patients who've had heart attacks, unfortunately, often STEMI, presented late, damage to the myocardium that doesn't get better and left with left ventricular systolic impairment. My suspicion is a lot of what you are seeing with COVID-19 in the heart is probably going to end up being benign in the longer term from the majority of people. In the, I suppose, almost for me, some of this is a bit like, you know, you may see some of them, their renal function may get a little bit worse and then gets better. You'd probably rather that hadn't have happened, but is that going to give you long-term sequelae? Probably not in a major way. My suspicion, therefore, is that, yes, there will be some who have a problem with this, but I do not think it will be the majority. So I think there is some concern about it, but I I just don't see it that way, because we've not seen it that way before with viral myocarditis. And my clinic is not rammed full of viral myocarditis patients. The majority of those patients actually do well. The biggest problem in cardiology, heart failure, actually is ischemic cardiomyopathy, and in my hospital, hypertensive heart disease. Those two completely dominate my practice.
I have to say that's encouraging, isn't it? And I think we do have or you certainly have the history and knowledge from other viral conditions to back up the more positive outcome that I think people will be scared around. You talked a little bit about arrhythmias potentially with SCAR, but I'm really interested in the work that you're doing around long COVID, and what are you seeing with patients who perhaps may not, who are recovering, and for how long perhaps?
So with the post-COVID side of it, you've got two groups. You've got the group of patients who are really sick, often in hospital, ITU, issues around respiratory, often lung issues. The group of patients we're sort of, if you like, seeing more of. So that's a specific group that often end up under specialist care. The group that we are more involved with, so there's a group of us across London that are looking at post-COVID syndrome cardiology, are more actually the majority of patients we see never had COVID that was never that bad. I mean, some of them had viral illness that wasn't particularly pleasant for a week. They didn't need to go to hospital. And so that's the group that we're seeing. And we typically see two main problems with this group. I would say from the cardiac, I mean, there's often other issues, but from the cardiac side, two things, palpitations and chest pain. By a country mile, those two things dominate the symptomatology that we see. So the question is what to do with it. With the palpitation, because I think there were various questions. With the palpitation side of it, you're always going to start with a 12-lead ECG. And obviously, fingers crossed, that's normal. I have to say my own practice is to do a 24-hour tape on anybody that sees me with palpitations. So I'm saying this with an air of caution because Nick is an electrophysiologist who knows better than me. that is my personal practice, because even the yield of abnormality is extremely low. We've all the patients we've seen with me, so there is a question, are you overwhelming services by doing this? But even if you don't find anything like, so things like atrial fibrillation, I would say here, and atrial flutter, it's very reassuring as a starting point to the patient. So we've had a good look at you, and when you're getting your palpitations, you're not getting fibrillation, flutter, ventricular tachycardia, whatever it might be. Your heart is doing what it should do. And of course, the typical finding is sinus tachycardia with this. And then that leads you to the conversation of what do you then do with the patient who's got sinus tachycardia and is bothered by it.
And I guess one of the questions that we may not know the answer is there a relationship between this and POTS? I guess if you've got tachycardia, have you seen anything around that?
Yes, and I think so. I work with Nick Gould, who is a POTS expert at King's and sees patients actually from around the country. For me, I think what we see so the question is, why would the post-COVID patient have sinus tachycardia? And there are various reasons why it may happen. So the key thing with this is sinus tachycardia is very, very, very rarely predominantly a cardiac issue. It's usually the heart being told to beat faster for a reason. It may be that the patient's detrained. So some of the patients I've seen, ultra fit, got COVID, detrained over 2 or 3 weeks, and are now worried their pulse rates they're probably just a bit detrained versus what they were beforehand. So there's a bit of that. If your lungs have had a problem, so if you've had viral pneumonia, clearly all these things are going to push your heart harder. The predominant issue probably, once you go beyond that, is probably neurologically driven. So POTS syndrome, postural orthostatic tachycardia syndrome, in effect, by definition, is your heart rate going up by 30 beats a minute when you stand up. And we often diagnose it on a tilt table, although you can diagnose it more simply just by a standing test and watching what your heart rate does. And almost certainly the issue is autonomic nervous system dysfunction that results in this. And I mean, at the end of the day, for me, I think what we're seeing, if you like, is a spectrum where we're seeing some patients with sinus tachycardia, it seems to be quite mild, responds actually very well to very basic treatment, and some where it's been more complicated and actually have more features that are wider than just the sinus tachycardia and suggest more POTS syndrome. So POTS syndrome patients often will have lower blood pressures, for example, other symptoms, sometimes breathing disorder issues, a lot of it relating to autonomic dysfunction. So I think for me, this is for different patients, this is a spectrum that we're seeing post-COVID. You're muted, Nick.
Thank you. I think that's very helpful. And there's a sort of pertinent question on a personal basis from one of the people in the audience asking about their own personal thing. They've had COVID. They've got symptoms of breathlessness. They've seen a GP. They're waiting for an MRI. They don't have you nearby, so it's going to be a long wait. Are they going to, what is the likelihood? Is this a rule of thirds? What is the likelihood of them having a problem in the future?
In terms of what, something like, could they have a cardiac issue with this on the face? I mean, so if you look at what we've tried to do with post-COVID, so we've obviously got to try and decide in terms of pathways, which patients do we want to see in cardiology, which patients are we going to be most useful for? So for the breathless patient, what we've generally suggested to GPs and to our post-COVID clinic is to do an N-terminal BNP, which is a blood test, which is a very good marker of, if you like, in inverted commas, heart failure. So we use it as a screening test. As the GPs on this will know, it's used very commonly in primary care as a screening test to determine who should or shouldn't get an echo in terms of patients who are breathless. So the starting point is a BNP. I mean, post-COVID breathlessness, of course, could be a multitude of things, but the more likely thing is obviously going to be the lungs. I mean, I can certainly, two of my colleagues in the office next door, clearly in the first wave had quite bad COVID pneumonia. They didn't need to come to hospital, but they'll quite happily tell you they were not the full ticket with their breathing. And they were really fit, both of them, not the full ticket for quite some time. I mean, the pneumonia side of it clearly took a long time to get better for them. But there was nothing to suggest there was a heart issue. So I think the starting point generally is going to be lungs. With that BNP, if BNP's high, then from a cardiology point of view, then you need an echocardiogram and go from there, sort of thing.
Okay, that's very helpful. And then BNP is a hormone that's secreted in heart failure that we use quite frequently. And I guess the sort of how do we? I mean, managing this problem long term and using the integrated health system to try and manage this. I mean, what sort of help do you and your colleagues need to get this sorted?
So I think it's quite interesting if you look across London what's happened with this, because UCL, so there's a cardiologist at UCLH, Rob Bell, who has the biggest experience of doing this, because actually their long COVID or post-COVID syndrome clinic, I think they got going possibly in the summer last year. I mean, they were miles ahead of the curve. And they just did it, as far as I can see. I don't know how they funded it, but they just did it. I think if you look at what is happening, I mean, I know, because this all goes on above, if you like, above my pay grade, because from a cardiology point of view, we're providing input to the long post-COVID syndrome clinic service, which is led by respiratory for us. There are a lot of pan-London NHS meetings, and I suspect this is going on in all areas around the UK about how you're going to fund this. I can't remember how much, but some of you will have seen this on the news. We were offered, I think it was about £300,000 just before the second wave in November, December time, where we were talking about £200,000-300,000 money from the government to get things moving. And that wasn't unique to us. That was, I believe, what the various different areas of the country have been offered. In reality, it sort of sounded like a lot at the time, but when you start thinking about the scale of what you need, it's actually not a lot. Yeah. and I would say a lot of the conversations are around how we're going to deal with the workload that's going to come our way with this. Is it going to overwhelm us, I think? Yeah. So.
Well, I mean, we need the ICSs to engage in cardiovascular care anyway, let alone this aspect. So I think that will be part of the thing going forward, isn't it? Any concerns about having the vaccine after having had myocarditis?
So the answer to that is, my personal view is no. We have had one case where somebody is presented with myocarditis. I think it was about a week or two after having had a vaccine. I suspect it was unrelated. I haven't seen other stuff in the literature about this. The MHRA haven't come back to us on anything about it. And I suspect, I mean, you know, to put into perspective, we probably see probably for getting COVID, myocarditis, probably once every couple of weeks we get a case. So it's not a surprise that you're going to see, this is a bit like the issue with the sinus thrombosis, but you are going to see this sort of thing happen because so many people are being vaccinated. And myocarditis is not common, but it's common enough that you see it, as I say, two, three times a month in a hospital of this size. So from my personal no, and my overwhelming view on things is, for all of this, you're better off not getting COVID or getting mild COVID because you've been vaccinated, rather than being worried about the risks of vaccination. That's my personal view. But we're, all the time.
Yeah. And the management is going to be a multidisciplinary approach, and with that, psychological support, rehab. So the question about exercise: can you exercise, or some terrible arrhythmia going to happen?
So the whole literature on exercise following myocarditis is extraordinary, and I mean, I often have trainees come to us and say, I want to do cardiology because you've got lots of good evidence base, and so much of what we do. The basis of the evidence for exercise and myocarditis is one paper from 1989 that looked at 120 mice and what happened to them when you injected Coxsackie virus into them, and watch what happened when you chucked them into a swimming pool for an hour a day, would you believe? So if you exercised some of them and you had a control group, didn't exercise, that when you gave the mice Coxsackie virus and exercised them, they tended to do a bit worse and get more myocarditis if they exercised than if they didn't. And that is basically the literature on this. There's a whole load of guidelines on it, and you can all read this as European guidelines and American guidelines on this, but they are proper opinion rather than based on data, because we just don't have data. So if you read the guidelines, what the guidelines will say, if you've had myocarditis, you generally look at this case by case. Obviously, there's going to be some sort of decision made about what you can and can't do based on how bad your myocarditis was. Was it mild? Was it very bad? Exercise is divided into three categories for us. So you've got the mild stuff, which is walking around the golf course, the moderate stuff, which is going for a jog or going for a cycle, or the more extreme stuff if you want to be a sort of triathlete. We worry a little bit about the more moderate and excessive sort of triathlete level stuff soon after myocarditis. As I said, we may be wrong to worry, but people will say, in the literature and the guidelines will say to you, 3 to 6 months of not doing that, and then you should have a physician workup where, depending, you're probably going to need another MRI scan, an ECG, a troponin, and some people, depending on what you're going to do, you may suggest they actually go do an exercise ECG at that point. And if all of those are normal, then you can get on with it. Okay. Now, the reality is, I don't think many people are actually doing that. And Nick's probably there thinking that's not what most of us wouldn't do that. I wouldn't put somebody on a treadmill. But that is what, if you've had reasonably bad myocarditis, that is what the guidelines would suggest. A lot of it's based around how much scar you've got in MRI. So you've got a lot of scar in MRI, you generally be more aggressive with looking for problems. The risk, as Nick was alluding to, is arrhythmia. The scar is a nidus for potential ventricular arrhythmia with this.
I think the message is we've got now is that you can have your vaccine and buy some golf clubs and you'll be okay.
Well, as somebody who loves golf, I'd have no argument with that. Yeah. However, I also love cycling, and I think it probably is important to say that, joking aside, we have many conversations in cardiology with people who are desperate to keep themselves fit, and I could not be a bigger proponent of this. Exercise is, for me, one of the most important, most efficacious treatments that we have in cardiology and in many, many specialties beyond cardiology. It is such a good thing in so many ways. And making attempts to stop people from doing it, it's okay maybe for a short period of time, but for a longer period of time is not without its issues. So always the push for me is wanting to encourage people to go back to exercising as soon as we think it is safely feasible for them to do it.
Well, that's really good advice and very helpful. Do you think your patients need to have anticoagulants afterwards and after myocarditis, or would you just go on normal guidelines around arrhythmias? I mean, there's a lot of talk about prognosis with COVID.
Yeah, I mean, this is difficult, isn't it? Because one of the problems I think in hospital is we're obviously seeing one end of the COVID spectrum of patients who've obviously been sicker with COVID. And I think probably anyone who's on the call here who's had clinical involvement with COVID will have thought there seems to be more clots with this disease than we're used to seeing, which of course in your mind starts making you think about anticoagulation. For myocarditis purely, I would say no, unless you thought the left ventricular function was particularly bad, in which case you might think about it. Even then you'd debate it. The main concern is going to be atrial fibrillation. So of course, if they've had myocarditis, pneumonia, the risk of atrial fibrillation will be higher. So, you know, all those things are going to be going through your mind. So from our perspective, atrial fibrillation gives higher risk of intracardiac thrombus. And of course, the risk then is if it comes out of the left atrial appendage, may end up in the cerebral circulation and cause a stroke. So as a general rule, no. But again, you're going to have to take this on a case-by-case basis from my perspective.
I hope Susanna would join us, but let's tackle coronary disease, because there's several aspects of that. And you know, have you seen more heart attacks in your hospital with COVID? Or
so the issue that we had with the first wave, and I think there was a question before we started about this. The issue we had in the first wave is at the beginning we saw less, and I do not believe that's because there was less happening. It's because people didn't want to seek help. And so we saw less heart attacks, and the people who were presenting later, which for us is a complete disaster. So the motto in interventional cardiology is time is myocardium. So if you're having a STEMI, ST elevation myocardial infarct, you've completely blocked a coronary artery. The quicker you open it up, the more likely it is the heart muscle is going to survive, and then you don't need to meet me in the heart failure clinic afterwards. So people presenting late is a complete disaster for us, because they're much more open to heart failure and all sorts of other complications that actually we don't see so much of anymore, because interventional cardiology has been so good at trying to fix STEMI so quickly. So in the short term, it was less. What we're seeing now, I think, is probably more based on the fact that, and we've known this with other viral disease. So there was a big paper just before COVID actually happened. There was a big paper in the New England Journal about influenza. It's a massive epidemiological paper in the New England Journal that looked at the fact that there were many more heart attacks. I forget the numbers, but there were many more heart attacks after patients had influenza than had. So there's something about what viral disease is doing to you that is making you more prone to this problem. The suspicion is, of course, it's probably related to cytokine activity. And probably if you've got a bit of atherosclerotic heart, it's making it presumably more prone to rupture. And hence, once it ruptures, you're then more likely to put thrombus on top of it and cause a heart attack in the vessel. As I say, this is not unique in itself to COVID-19. It's been well described in influenza too. The last thing I would say is perhaps a small print just of interest from an academic side. Labeling people with a heart attack isn't as easy as it might sound. So with a STEMI, it's easy. So patients got whopping great ST elevation on a ECG, goes to the cath lab, blocked vessel, no debate. The smaller troponin rises are much more difficult. And a lot of the studies that we do are heavily pushed towards what you do with small troponin rises. Patients got some chest pain, small troponin rise. How do you know it's not myocarditis if you don't put someone through an MRI scan, particularly after influenza or COVID? So some of it may be a bit of overcall, but we've all seen, and we've had a whole number of cases here of quite nasty heart attacks in multiple vessels in COVID patients. So there's clearly some patients get overactive thrombophilia type reactions, and presumably the inflammation is making hearts likely to rupture in the coronary arteries.
Yeah, so it's a real note of caution, and I think it is. I think that point you raise of people avoiding coming to hospital and getting delayed treatment and storing up problems for the future really important, because I have to say in the second wave we're doing very well, but recently we've reached the same problem. People have presented very late and younger, which is a bit of a worry, and let alone the strokes. So I think that's things to bear in mind around that. There's some questions around whether people who are prone to arrhythmias are likely to get more arrhythmias after COVID. Did you have a sense around that?
You probably answer that better than me, Nick. I mean, I would say, the answer is almost certainly going to be yes. I mean, it's not uncommon if you get pneumonia to end up with atrial fibrillation. So if you're more prone to atrial fibrillation, so if you've had it before, so something in your heart is prone to it, if you then end up with COVID pneumonia, I'm sure you're going to. I mean, have we seen it? Yeah, plenty. Yeah. I don't know the literature in terms of going beyond what my own experience is. You may know better than me, Nick, but I'm sure the answer is going to be yes to that question.
Yeah, I think the literature is probably a little bit weak in that direction, but yes, I think you probably see a pro-arrhythmic effect. There's an interesting question which goes back to what you talked around working in primary care. There's patients who have been investigated with normal CTPA, normal tape, just showing signs of tachycardia. And I guess, how do we think we're going to go and get that message out to primary care so that they don't have to worry? And then if you do have sinus tachycardia, are there any drugs that you think about utilizing to manage that?
So how I deal with the patient with sinus tachycardia, again, it's done a bit case by case. The first thing I will always do is reassure that the patient will think, oh God, am I going to have a heart attack? Is there something terrible going to happen to my heart? So you reassure and say, your heart's fine, your heart's normal. It's beating faster because it's been told to do so. I think that we have a challenge around where society's gone with monitoring. So lots of people come to us saying, I wear my Apple Watch, and some of them will come to me with an Excel spreadsheet and say, 10 past 10, heart rate this, 11 minutes past 10, heart rate. They've become completely obsessional with heart rate monitoring. And I don't think that psychology is probably helping. So I'll turn to look at all of that. Try to avoid dehydration. Some people have found salt intake can be helpful with this. And at that point, I'll try and do nothing more and just see what happens. So some basic, just, you're not going to die with this. Try keep yourself well hydrated. Try and stop looking at your Apple Watch and monitoring and see how you go. If that makes it better, wonderful. If not, then the next step is to consider things like beta blockers or ivabradine. We tend to use beta blockers first up with this. In the POTS type patient, sometimes more difficult if the blood pressure is on the low side. Sometimes ivabradine is a better bet. Some patients, and Rob Bell will tell you this, I mean, Rob's had huge success. So Rob's the consultant who does long COVID, post-COVID syndrome at UCLH, had tremendous success actually with a beta blockade. Certainly some of my patients have done really well with it. So sometimes just low dose actually slows things down, patient feels with it, and you sort of break the cycle. They feel better and they start doing more, they get fitter, everything sort of starts to improve. Going beyond that, from my perspective, I think requires referral. I think primary care, and I'm sure in psychiatry we've talked about this before, are generally going to be happy to use a little bit of beta blocker. I think if you're not winning at that point, my personal view is that a cardiologist ought to be involved at that stage to take that forward.
There's a really interesting question about ethnicity and myocarditis, and let alone the whole question around BAME and COVID. Have you seen it at sort of preponderance? I know you've got a hypertensive population, which may be a group.
Well, I work at King's, and our local demographic here, we have many patients who are African American, African Caribbean. As many will know, in wave one, the patients from those ethnic backgrounds actually were, I think, the dominant inpatient group here. That didn't happen, and we don't understand why in wave two. Whether it was we just don't know. It was something to do with the change in the virus. In terms of myocarditis, I would say personal experience. The literature on this is mixed. My own personal experience is biased because of the patient group that I deal with. We do seem to see more of this sort of thing in patients of African American, African Caribbean background, I think, with this. But that may just reflect what patients, what our patient local ethnic background is. So I don't know for sure. And so I answer that just with, with a sort of N equals whatever of my own experience rather than necessarily what the literature suggests.
Yeah, it's probably consistent, to be fair. I think nationally, I think there is no doubt several-fold increase in risk and an outcome. So
without question.
There's some very good advice around palpitations, is to ask our patient to reduce their alcohol intake, and I suspect in times of restriction and people being at home, it's probably very pertinent.
Yes. Yeah, I mean, you know, there are all sorts of, external things that can cause sinus tachycardia. Things like alcohol not going to help you with arrhythmia. Of course, ecstasy, cocaine in the younger population, all these things are going to push you to drinking too much Red Bull. You know, these things are going to push you in the direction of sinus tachycardia. And so sometimes the answer is as simple as trying to address things like that. Absolutely.
And with myocarditis generally, we've got some treatments around colchicine and steroids, avoiding non-steroids. I mean, is there anything different or in terms of treating acute myocarditis?
So the data is really all around pericarditis with this. So obviously the pericardium, the lining of the heart, sometimes you will end up with pericarditis with the myocardium being left pristine, and quite often the two will coexist, so you get myopericarditis. Pericarditis, as many of you will know, is much more of a clinical diagnosis. Patients will often have a high CRP, will often complain of typical type chest pain, so it's often sharp sort of pain, left-sided, worse on a breath in, worse lying down. And colchicine and non-steroidals are often very effective for that. The evidence base around using those things in pure myocarditis is much more limited. It's a clinical trial actually that we'd quite like to do. It's the answer to that. We've been talking about it for I think probably about a couple of years now. It's just trying to find funding for it. It's a massive amount of money needed to do the trial. We have quite a low threshold for using colchicine. So some on the call may know that there's recently been a big trial in myocardial infarction looking at colchicine, showing that patients do better post-MI with colchicine. So clearly colchicine is doing quite a lot of good things for the heart. You know, it clearly works in pericarditis, it clearly works in myocardial infarction. I think it will work in myocarditis, and we're using it, but we do lack data to know for sure. And in fact, I mean, some of the patients that we've dealt with post-COVID syndrome who've had what we think is myocarditis have done very well with colchicine. So it's quite a nice drug. It's pretty benign. Diarrhea is sometimes a problem, but it does work well in that setting for many patients.
And colchicine, traditionally anti-inflammatory agent used in gout and rheumatoid arthritis, so very, very helpful. I guess a question that we don't ask very often is cardiac MRI available around the country? Because I know certainly in Wales there was a struggle for a while. Have you got any update on that?
So around England, every hospital will have access to referral. So not every hospital will have cardiac MRI in-house, but every hospital will have access to somewhere local that does it. So there is no area in England that will struggle with that. In Scotland, actually, there are some big centres that do it. Glasgow's a massive centre, and Edinburgh, a big centre for cardiac MR. Wales has struggled a little bit more with it, but as I understand it, the last I heard with this, because I know the TPD there, Claire Williams, that is improving now. So there is definitely much better access to cardiac MRI in Wales now as well. Northern Ireland, I don't actually know. Again, I know it's done there because we had a fellow here who was talking about it, but I don't know again how easy it is to access. I remember her telling me that echo was quite difficult at that time. This was probably 2 or 3 years ago. Echo waiting times were quite long. So what I would say is we're very lucky in the UK. We actually have wider access to cardiac MRI than the vast majority of countries on the planet, including the States. We do more of it here than actually per capita than the United States do.
That's good. And another good question is that in non-COVID patients, we're seeing increasing evidence of microvascular ischemia or microvascular disease. Is that more so in COVID? Are these what the scars are related to, or is it just inflammation?
There is some theory around this. I would say the post-mortem studies don't suggest there's a massive amount of that. But as I said before, you've got to appreciate that that is only looking at a certain cohort of patients. The Imperial College Royal Free study I talked about before, they did find microvascular disease in some patients. I don't think it was a massive number. I think it was sort of around maybe 10%, something like that. Very possible. I mean, certainly if you're very thrombotic, some of it may be that you're just showering a bit of emboli into the distal vessels. Some of it will be issues around ischemia itself, probably just from the vessels getting pinched, maybe from the area around being inflamed.
So I guess in some of the long COVID patients, there might be an element of that outside their breathlessness, which be consideration. It's probably slightly unfair, but you might know more than that. Do you have any experience around the use of PET and in terms of a test for inflammation and COVID?
So cardiac PET is an extremely effective way of looking at cardiac inflammation. So with my sarcoid hat on, we use it all the time with sarcoid. It's just accepted practice to do it in sarcoid. And so your question is very pertinent, because at the moment we are talking to various PET departments about thinking about doing this. So in patients where, for me, patients where you've got a borderline MRI, particularly around the issues I showed you, thinner myocardium, and you're really not sure, I actually wonder whether PET scanning is useful, but we don't know. Again, these tests have been designed, being blunt, for more gross disease processes. The question is, what are they going to be like at picking up the more subtle stuff? So without question, I mean, if you want to put a patient who's got quite nasty COVID myocarditis through a PET scanner, you will see impressive information. What I really want to know is, what about the patient who's got much milder subtle disease? We don't know. So again, it's research.
I guess if it's vascular and it's inflammatory, it will spread along the aorta down to the mesenteric. There's a whole load of people who got abdominal pain with COVID.
Well, the beauty of PET scanning is, of course, you get a whole body picture. With MR, you do a cardiac MRI, you'll get sort of neck to diaphragm of imaging, but you won't do inflammatory imaging of all those bits. You'll just do the inflammatory imaging. So the PET gives you everything, and it's a nice technique from that perspective. Obviously, the downside is it's irradiating you, but it is an extremely potent way of diagnosing inflammation in all sorts of different bits of the body. Absolutely, yeah.
I might just switch back to sort of the long COVID element. I mean, it's a bit early in the process, but do you have a sense of the timescales it takes to recover? I mean, do you feel that the vast majority might be over it in 3 to 6 months, or is there any way you can put a number around that?
I think it's difficult, isn't it? I mean, we know that the majority of people will feel better after about 12 weeks, but some don't. And I think, if you sit in the meetings that I sit in, listening to the respiratory guys who are running the service, there is a concern about this. How long is this going to be something quite short-lived? This obviously will have a massive impact around what clinical services need to provide. So I think with all of this, that side of it, we're just learning as we go along with it. And you just hope that the majority of patients, as they go through the system, will improve, given a bit of time and some medical help, actually will get better over the course of who knows how long, but hopefully fairly quickly.
I think we'll see. I mean, as you say, you're seeing more and more research into the area to give that. I was looking, there's over 4,000 publications on COVID in the heart. So I didn't read them all last night, but but interesting, most of them are North America and the UK are really strong publishing house for looking at this data, which is encouraging. I think if it's a shame, again, the same Suzanne's not with us, but in using our combined experience, I think the sense we had was that people are now presenting younger with COVID in this wave. Yeah. And we had a sense that, are they sicker, do you think?
I mean, it's hard to know. I mean, we had an ITU that was, being blunt, pretty overwhelmed with patients. But was that just because they were more sick patients this time around? It's hard to know. I mean, the impression you get from the national data is that possibly the patients were a bit sicker. I don't think it was a massive difference, but I know, I remember Chris Whitty and Patrick Valance talking about this, that they did think, certainly, this was probably a month or two ago, they did think that the Kent strain was a little bit more unpleasant in terms of outcomes. So possibly, part of me wondered whether could some of that be to do with the fact that so many people got it, that hospitals struggled even more to cope, and therefore prognosis was worse off because of the disease, but because we just didn't cope so well with being thrown in. Who knows?
Yeah, and I think there may be an element that we got better treating the moderate, and
Yeah.
avoiding ITU is certainly the ethos, going for CPAP and trying not to get into the ITU. So the sickest of the sick, weren't they? So
I couldn't agree more. We were much more aggressive on the wards than we were first time around. Because I remember first time around, there was a lot of stuff from Italy where people say, oh, you know, these patients go off quickly, you intubate them quickly. And of course, that's sort of, I think, what happened. Whereas, as you say, second time around, dexamethasone, CPAP, we were, yes, I agree, we were doing more on the wards without question. Yeah.
And I think from our own cardiac point of view, I think we know that our cardiac patients have a sort of 3 times higher risk to get to ITU. And with you talk very well around the troponins. If your troponins up, it's a 10-time risk of getting onto the ITU unit. So we certainly have to be cautious in that group, and we have been. Any sort of thoughts about how your service is recovering? Because I think that's an important bit, isn't it? We've done very well managing the sort of first, second wave of COVID, but what about regular patients who don't have COVID? How are you managing that?
It's been a struggle. So in heart failure, it's difficult because heart failure doesn't lend itself that well to phone consultation. You know, examining the patients often important. I mean, some of it's fine, but some of it's been difficult. So we're doing the best we can to see as many patients face to face as possible now, and trying to catch up in that regard. I would say certainly in our hospital, diagnostics are, you know, for imaging are, you know, have longer waits than we would ideally want, but we're trying to do our best to do something with that. EP, so certainly with from Nick's point of view, I mean, there's an awful lot of patients waiting for atrial fibrillation ablation procedures now. I know, and I think, as I understand it, I think that's an issue in all the London centres, and I suspect far beyond London. So, you know, we are far behind where we want to be. Surgery also, I mean, our surgical unit shut for a period. You know, there's a lot of people waiting longer than we would want them to wait. And, you know, we hope that we're going to go hard at it to try and get things better as quickly as we can from that perspective.
Yeah, and I think it's also, I mean, it's changes in practice and behaviour. So I think that traditionally somebody with chest pain would automatically get a test, etc. But there's a better evaluation of that, and we know medical therapy is good in stable angina. I think there are pathways around surgery that where angioplasty is feasible with a good multidisciplinary approach to help move with those waiting lists. So there is change happening with that. So that's been very good. More work for us all. So I think we're come to a point. So I think we really demonstrated the breadth of how COVID and cardiology work together. The COVID virus affects our patients, causing myocardial infarction, causing myocarditis and heart failure, and being, I think, in our sense, being pro-arrhythmogenic as well. So COVID does affect the heart. We've learning more and more around it, and I'm really pleased to hear the advances being made, and also just how we're managing the patients who've left the hospital and who've got this so-called long COVID syndrome. And you're right, the palpitations and the chest pains are a real concern to our patients, and it's probably reassuring to know that no little harm is coming to them. It's really trying to manage their expectation, and also look at treatments that we can have for them. I'd like to also, for those of you know, announce that we have a fantastic webinar next week on the 1st of April, where Professor Chris Whitty is talking to the RSM, and our ex-president Simon Wesley will be interviewing him. So that's next Thursday, 12:30 to 1:15, and our normal Thursday slot. Dan, I can't thank you much. I'm really sad that Susanna couldn't join us, but she is managing a very sick patient. It's been a real run through of cardiology in the heart, and I'm really grateful that you've taken us through all that. Thank you for your time, and thank you, the audience, for those fantastic questions. Our message, and I talked to Susanna about this earlier on, is that we mustn't get complacent. We must be careful. We must support the vaccination program. We must ensure that the basic measures around social distancing, hand washing are still adhered to. That is the area that will prevent the most mortality and morbidity, and I hope you'll take that message away. Dan, thank you very much again, and thank you, audience, for listening today. Thank you.
Thanks, everyone.